Welcome to Tip 26, Substance Abuse Treatment with Older Adults, brought to you by allceus.com. Abuse of alcohol and prescription drugs among adults 60 and older is growing extremely quickly. It's estimated that 2.5 million older adults have problems related to alcohol and consume more prescribed and over-the-counter medications than those under the age of 65. Treatment is worthwhile with this population, and the elderly can successfully be treated. Age-related changes affecting the way an older person responds to alcohol include a normal decrease in body water that comes with age and a decrease in the rate of metabolism. What does that mean? That means the same amount that they used to be able to drink before or take before can now cause intoxication, and they have an increased sensitivity and a decreased tolerance to many drugs, not just alcohol. Additionally, their liver is slower at getting some of the stuff out of the body, so it's important to remember that it's easier for them to become intoxicated or to reach lethal levels of certain medications than it is for someone who is younger. Alcohol can also trigger or worsen other problems that are going on in the older adult, including heart problems, stroke, cirrhosis and other liver diseases, gastrointestinal bleeding, and any mental health problems that are currently in existence. And those may be organic mental health problems or situational due to grief and loss, etc. Many medications that the older adult is taking negatively interact with alcohol. So it's important to help the older adult realize that alcohol is now something that they can't just drink and take for granted. Many older adults also become dependent on psychoactive medication, which can cause problems, especially if they are concurrently drinking alcohol. Misunderstanding directions is another key problem with older adults. I know my grandmother, bless her heart, doesn't like to take medication. So even with the antidepressants, which you have to take every single day, as soon as she starts feeling better, she quits taking them cold turkey. Or she'll only take it when she's having a bad day. And a lot of what she experiences is a placebo effect, because we know the medications are not acting that quickly. So it's important to make sure the older adult understands the instructions for taking the medication and the necessity for the prescribed schedule. There's also a risk of multiple prescriptions from different doctors not being coordinated. They may be going to an endocrinologist for one thing, they may be going to a pain doctor for another, they may be going to an orthopedic for yet another. And if the doctors aren't communicating, the older adult may be getting multiple prescriptions that actually conflict with one another. And many older adults, number one, just assume the doctors are communicating. And number two, are not real reliable resources of what medication they're taking. They forget the name of it, they forget what dosage they're taking, they may forget to list the medication altogether. So it's important to have the older adult bring their medications with them so you can write down who's prescribing it, what's being prescribed, etc. When we screen an older adult, we have to notice that psychoactive substances are often associated with negative central nervous system effects. Indications of problematic use in the older adult may include diminished psychomotor performance. That is, they're not as coordinated, they're not as nimble as you would expect them to be. Impaired reaction time, loss of coordination, falls, excessive daytime drowsiness, confusion, aggravation of their emotional state, amnesia, or substance dependence. With the exception of substance dependence, a lot of these other symptoms can be symptoms of other problems going on, such as dementia. So it's important to make sure that there is an effective differential diagnosis completed before you start trying to convince the older adult that they're addicted to a medication. Many older adults are not going to want to admit that there's a problem. There are a lot of risk factors for older adults becoming dependent on alcohol and other drugs. Bereavement and sadness. This is especially true as they start to lose spouses, friends, family members. Their social status may change. If they used to be running in the circle with their husband's friends, when their husband passes away, they may not feel that same connection. There's a loss of occupation and a sense of professional identity as they retire, as they become less able to do the same occupations they used to do. And their hopes for the future change. At a certain point, some of the things that they thought they were going to do, they have to realize they're not going to do anymore. At 75, they're probably not going to climb Mount Kilimanjaro. And their ability to function may be decreasing. And this is a loss of independence is a huge thing for a lot of older adults to cope with when and if it happens. There's also some element of social isolation and loneliness, whether it be because the older adult doesn't or can't leave their house or is not as mobile as before, or their children and their grandchildren have lives of their own and they're not coming to visit as much. The older adult tends to feel isolated and more lonely. There may be a reduced self-regard or self-esteem as they lose their past capacities. They need to be encouraged to develop new hobbies. My grandfather developed Parkinson's when he got older, and he used to be a painter, and he used to make miniatures, and he was extremely skilled. He made beautiful miniature dollhouse furniture and stuff. But as his Parkinson's progressed, he just shook too much and he couldn't do it anymore. And he didn't know what else to do with himself. Those were his hobbies. And when he couldn't paint anymore and he couldn't make miniatures, he didn't really have a sense of who he was or what he could do. And he fell into a pretty deep depression. So it's important for us as counselors, if we see this happening, to help the older adult find new hobbies, new avenues, new ways to reinforce their self-worth. Family conflict and estrangement comes up with the elderly. Who's going to take care of mom? Who's going to take care of dad? There's often, unfortunately, a lot of, I'll use the term, discussion about who gets what in the will, and a lot of really nasty, ugly things end up coming up as the person ages. Older adults may have problems managing their leisure time. They may get bored. There's not as many things to do if they're starting to lose their physical capacities. Help them connect with senior centers, help them connect with volunteer organizations, foster grandparent programs, call your local United Way, call your local elder care organization to see what's out there to help people in this age group connect with their peers. And there's also a loss of physical attractiveness. Whether we like to admit it or not, as we get older, we get wrinkly. And what we looked like when we are 20 is not what we look like when we are 80. Helping the older person adjust to that is another step in helping to buffer against depression and anxiety. Medical problems, again, this is loss of capacity in some way, shape, or form, may include loss of sight or hearing, physical disabilities, chronic pain, and chronic pain is another big one for the older adult developing dependence. Because the pain is there, and because a lot of the pain medications can be extremely strong, can have a much stronger reaction in the older adult, there is a tendency or a greater likelihood, a greater ease, if you will, for the older adult to become dependent and or abuse pain medications. Reduced mobility, insomnia, and cognitive impairments and changes. As their short-term memory goes, as they have difficulty remembering day-to-day things, if they do. Now, there are a lot of people who believe that if you don't use it, you'll lose it. So helping older adults interact early on. Don't let them become stagnant and sit by themselves in a nursing home with no interaction, whatever, because they will start to lose their focus and their sharpness. Help older adults remain engaged, and that will reduce some of the cognitive impairments that may not be organic. There are other practical problems, such as impaired self-care, dislocation from housing, reduced coping skills, and loss of income or increased healthcare costs. Reduced coping skills, not so much. I mean, if their mental faculties are sharp, they can probably maintain most of their coping skills. Dislocation from housing is a big thing. If they lived in the house that their kids grew up in and they've been there for 30 years and all of a sudden they can't live there because they need to be in an assisted living facility, that's a huge issue. That's a huge loss, a huge change. And as older adults develop more health problems, there are increased healthcare costs, which, if they're on a fixed income, can become extremely challenging. So we need to look at the older adult from a biopsychosocial perspective. Physically, what may be putting them at risk? Financially, what are their stressors? Environmentally, what are their stressors? Socially, occupational, you can use that term broadly. Even if they can volunteer, if they can mentor, if they can do something where they feel a connection, where they feel they can share their wisdom, as Erickson would say, that will help a lot in buffering against depression and anxiety. Other issues. Older men tend to be at greater risk of substance abuse after their wives die. There are higher rates of alcoholism in medical settings, interestingly. There's also a higher rate of substance use disorders in older adults if they had a problem with it early in their lives, which makes sense. Because we know that substance abuse is a lifelong issue, whether you want to call it a disease or not, that what worked to help people numb their feelings and to cope at one point in their life, whether it was the healthiest way or not, may reemerge when their traditional coping skills start to fail. If they have mood disorders, if there's a family history of substance abuse, or if they're using psychoactive prescription drugs, all of these are risk factors for the development of substance use disorders in the elderly. So, who do you screen? Every older adult should be screened at their annual physical during major life transitions, such as when the children move out of the house, when their spouse dies, when they retire, when they move to an assisted living facility, etc. Any major change in their life may warrant screening. And or if they start displaying unexpected or unexplained physical symptoms, they're somatizing their depression or anxiety, or they're displaying physical symptoms indicative of substance intoxication. Physical symptoms. There's the potential for development of an addiction when the person starts developing sleep-related problems, cognitive difficulties, seizures, malnutrition, and muscle wasting, liver function abnormalities, persistent irritability, altered mood or depression, unexplained complaints about chronic pain, and incontinence, urinary retention, or difficulty urinating. Now, all of these can lead to the development of an addiction, and all of these can also be symptoms of an existing addiction. So it's important when any of these come up to figure out why. None of these are normal issues that should just be left unattended. If they start demonstrating poor hygiene or self-neglect, again, that can indicate the development of depression, which may put them at higher risk for substance abuse, or it could indicate that they are abusing substances. Restlessness and agitation, complaints of blurred vision or dry mouth, unexplained nausea and vomiting, changes in eating habits, slurred speech, tremors, poor motor coordination and shuffling gait, and frequent falls or unexplained bruising. Some of these things you also want to check and make sure that there is not some situation in which the elder person is being abused, especially the alleged frequent falls and unexplained bruising. Poor hygiene and self-neglect may also indicate that there's some abuse going on. So it's important, again, to screen when you start seeing these symptoms if they are developing depression, anxiety, if they're being victimized, or if they're abusing substances. If the person has delirium and or dementia, whenever there's a presence of a severe cognitive impairment, it's going to be difficult to screen the person. It's also going to be difficult to differentiate when there is delirium due to withdrawal. If you suspect that it's withdrawal-induced delirium, this is a medical emergency. The person needs to be in a medical facility. Most detox units are not equipped to handle a medical emergency of this severity. Signs of delirium to be aware of. If the person presents for screening, for detox, whatever, and they're disoriented, they have impaired attention and concentration, they're anxious or agitated or suspicious, they have hallucinations, delusions, or speech abnormalities. All of these are issues that you need to pay attention to because they indicate something's probably seriously wrong and there needs to be a medical eval. Dementia is a chronic, progressive, irreversible cognitive impairment. It complicates your ability to monitor drinking outcomes, to get clients into treatment, and for clients to get benefit from treatment. They're having problems processing things. They're having problems remembering what's going on. It's going to be really hard to engage them in a treatment program. It's bad enough for the person who doesn't have dementia when they're going through coming out of the fog and detoxification. If you add dementia on top of it, you can imagine how hard it is for that person to focus. Signs of dementia include impaired short and long-term memory, difficulty with abstract thinking and judgment, language disorders, personality changes or alterations, and mood disturbances. When you're talking about detoxification with the older adult, there are certain things that indicate a need for inpatient hospitalization. There's a high potential for developing dangerous abstinence symptoms such as seizures or delirium if the person has had a high or prolonged dose of benzos or barbiturates. So if they were prescribed or if they were taking benzos or barbiturates at a high dose or for a long period of time, probably want to have them under medically supervised detoxification. If they abruptly discontinued the drug that they were taking, alcohol or otherwise, they may need to be in a medically monitored facility. Or if they have a past history of medical complications during detoxification, it's important that they be put in a facility that's prepared to handle whatever happens. If they have suicidal ideation or threats, really important that they are in a place where they can be monitored 24/7. Or if there's any other major psychopathology going on, such as panic disorder, depression, anything else that may be going on that may be exacerbated as the person detoxifies. If the person has unstable or uncontrolled comorbid medical conditions requiring 24-hour care, such as kidney disease, diabetes, and high blood pressure is another one I'll throw in there that we used to see a lot, that usually ended up requiring significant medical monitoring. If the elder has mixed addictions, especially including alcohol, it's important that they be in a medically monitored facility because there are a lot of interactions between the drugs. As we've talked about in other courses, 1 plus 1 does not equal 2 when you're mixing substances. A lack of social supports in the living situation, living alone, and or continued access to the drugs of abuse. So if they're living alone, it's probably not a good idea to have them on ambulatory detox. If they don't have good social supports, or if they still have access to the drugs of abuse, or alcohol even, I would personally think it'd be a more sound clinical judgment to have them in a medically monitored facility. Brief interventions can be used with elderly patients, but it's important to be non-confrontational and supportive. A lot of people in this generation still believe in the whole issue of you don't air your dirty laundry to strangers. There are significant shame issues associated with substance abuse and mental health issues. So it's important to be very supportive and not calling people out. Be very empathetic, understanding. Provide them customized feedback and information that they can understand about how the drugs are interacting with their body based on their age, their health, and their medications. Explore their reasons for drinking and the consequences of their drinking. So it's important to individualize this. What are the consequences for you of your drinking? Look at physical consequences, psychological, social functioning. One of the fastest growing, unfortunately, populations that is experiencing HIV disease is the elderly. And one of the reasons here is, again, because there's a lot of socialization, shall we say, that goes on in some of the assisted living communities. And they sound like they're really fun places to be, but elderly patients are not as well educated about HIV, about bloodborne diseases, and they don't take the precautions that they may need to. Some because they don't know about it, and some because they figure, well, they're old, they're going to die soon anyway. It's important to make sure that this population is also educated about how drinking is a disinhibitor and can lead them to make poor choices and have unprotected sex. Discuss with the elder patient key motivations to cut down or quit, such as maintaining independence, maintaining their physical health, financial capacity, and mental capacity. Help them identify sensible ways to cut down or quit, such as sober social engagements, getting reacquainted with hobbies and interests, and pursuing volunteer activities. Develop a drinking agreement prescription. A lot of older adults are very compliant with prescriptions. If the doctor tells them it is so, then it is so. So if you develop the prescription with them, there's maybe a higher level of compliance. Brainstorm coping methods with them to help them overcome social isolation, boredom, and negative family interactions. And then summarize every session, preferably verbally, and also write down notes about things that you talked about and things that they're going to do in the next week. So they have visual cues as well as reviewing it with you. You can use the frames approach with elderly patients. Provide them feedback on their personal risk or impairment as you understand it from the screening and assessment. Put the responsibility for change on their shoulders. Don't coddle them. They are not inept. They are not ill-equipped. They will be more responsive if they are given the responsibility for changing. Most elders feel like it is their responsibility to take action. Provide them information. I don't like the word advice. They needed advice for an A, but provide them information about how to go about changing. Teach them how to create treatment plans and goals. Provide them a menu of options so they can develop 2 or 3 alternatives to whatever behavior they're trying to change. Be empathic. Support them. Help them know that you understand that change is difficult and this is a huge step for them. And support their self-efficacy through ongoing follow-up. Check in periodically and see how they're doing. Don't just do a treatment plan and say, okay, see you later. Have them do a step-down sort of arrangement in their treatment. So maybe they come in weekly for the first 8 weeks. And then if they're doing well, once a month for the next 3 months. And then come back in for a 6-month checkup. This supports their self-efficacy because you're letting them step down and communicating to them that you believe they can do it and they don't need you to do it for them. But it also provides them that stopgap so the door is still open, so to speak, if they need help. There are treatment settings for elders just as for everybody else. Inpatient treatment can be used when there are medical complications, when the social situation or environmental situation is not conducive to recovery. Treatment approaches that can be used in inpatient or outpatient include age-specific group treatment, which is, again, supportive and non-confrontational, and builds or rebuilds the patient's self-esteem. The focus needs to be on coping with depression, loneliness, and loss. These are all common themes in the majority of our elderly patients who come into treatment. On rebuilding their social support network. But the pace and content needs to be appropriate for the older person. Again, you need to remember that especially if they're in recovery for substance abuse, in addition to maybe some other mental health issues, the pace needs to be a little bit slower. Use as many visual aids and visual prompts in addition to talking about it and verbal cues as possible. Use all the senses if you can. Engage staff or hire staff that are interested and experienced with working with older adults. We have found it to be extremely effective in our programs, especially our outreach and prevention programs, to use elders and even elders in recovery to lead some of the groups. And we found the response to be better than necessarily using someone with more training who's 24, 25, 26. It's something to consider. Does it mean you have to use elderly people to counsel elderly clients? No. The person who is doing the counseling simply needs to have the sensitivity. I'm just saying from our experience at my clinic, especially in outreach, it's easier to develop rapid engagement when we were using counselors that were of a similar age group and or background. It's important to provide medical services or access to medical services. and case management. Just like anybody else in treatment, this is not specific to elders. They have biopsychosocial needs that require wraparound services. If you have a single point of contact, whether it be a case manager or the counselor, because many of us don't have the luxury of having case managers for every client, that single point of contact can help the person learn how to link with the agencies that can help them out. There are 5 treatment approach principles. Treat older people in age-specific settings. Create a culture of respect for older clients. That means don't call them by their first name unless they give you permission. That means don't show up to treatment as the counselor and be wearing shorts and flip-flops and a tank top. Be on time. Recognize and communicate through your actions that their time is just as important as yours. Take a broad, holistic approach to treatment, emphasizing age-specific issues. Have a flexible program. Some of your elders may go in and out of the hospital, may have rapidly fluctuating issues that you're going to need to attend to. And adapt treatment to the client's gender. When using cognitive, behavioral, or motivational approaches, you're going to identify the negative consequences of use. Help them shift their perceptions about the impact of use from it's not a big deal to it is a big deal. You're going to empower the client to generate insights and solutions. How do you see this affecting you? And what would happen if you weren't using anymore? How would your life be different? Express belief in their capacity for change. You're not too old. It's not too late. You can do it. Matter of fact, you have more knowledge than most people. So let's build on the knowledge and strengths that you do have. Help offset the denial, resentment, and shame. Confronting denial straight on, not going to work very well. There may be a lot of resentment either about being referred for treatment or towards others in their past, and they will need to deal with that resentment in treatment. Destigmatize the issues that they're dealing with. As I said before, a lot of older adults feel a great amount of shame about not only substance use and abuse, but also about mental health disorders. So it's important to destigmatize this, help them see who that they looked up to, what icons of their generation had depression, anxiety, substance use, and overcame it. Focus on rebuilding social support networks. Help them develop self-management approaches for overcoming depression, grief, and loneliness. And help them work on general problem solving. One of the wonderful things about doing this in a group setting is a lot of this can be accomplished in group. The group becomes a social network. The group can work together to help each other develop self-management approaches and general problem-solving strategies. So if you develop an effective working group, your job is going to be a whole lot easier. There are 2 basic approaches in group: educational and theoretical, and personal practical. You want to start out every group by clearly stating the goal and purpose of the session and outlining the content. Either putting it up on an overhead transparency, a PowerPoint, or preferably a handout that they can hold with them. Make sure the type, the font on any written material is sufficiently large to accommodate people with visual impairments. Don't use 8-point font. Preferably 14 at the minimum. 14-point Times New Roman. 12-point Arial can accommodate as well. Present an educational piece. We're going to learn about this. 10 minutes, 15 minutes tops. This is the skill we're learning today. This is what we're talking about. Spend the rest of the time helping people apply that skill to past situations, anticipate how they're going to apply that skill to future situations, and role play that skill or concept in group. Present topics sequentially, building block style. And each session should begin with a review of prior building blocks, such as, over the past few weeks we've reviewed X, Y, and Z. Now we're going to talk about this. Incorporate as many of the senses as possible. Visual, what you see. Present graphs, present charts, present videos. What they hear, what you talk about, again, in videos. Role plays, things that they hear. Also, manipulative. Present information in a way that they can role play it. They can apply it to their life. They can actually kind of use the material in a safe setting to get a handle on how they're going to do it on the outside. Groups should not be any longer than 55 minutes. Most of my groups, especially in early recovery, were 45 minutes tops. At about 40 minutes, people started going off into la la land if they were still in their first 28 days of early recovery. And this was true for older patients and younger patients. Pay attention to where your people are in the recovery process. Are they still in the fog? Are they able to focus? It's better to do a group that has like a 20 or 30 minute first half, a 15-minute break, and a 20 or 30-minute second half in early recovery than it is necessarily to do a 60-minute group and then give them a 30-minute break. Most people's attention spans are not that long. Rooms should be well lit without glare, interruptions, or noise, and superfluous material needs to be kept to a minimum. So try not to be throwing out all these bells and whistles and doing extra things. Try to minimize any distractions. Try, again, to minimize people getting up and going to the bathroom, whatever, leaving group, anything that might be distracting to the rest of the group. Individual counseling, medical and psychiatric services, marriage and family counseling, and case management are also important components of any well-rounded treatment. When it comes to staffing, everyone who works with this population should have training in gerontology. They need to enjoy working with older adults, and they need to have training on empirically demonstrated principles that are effective with older adults, regardless of whether they are the primary care givers of elder clients in your program, or they only interact with the elders for, a brief period of time. It's important that everybody have some training. There are many issues that are unique to treating older adults. Substance abuse treatment in this population is both necessary and worthwhile. And you want to help clients by providing treatment in peer settings, by persons sensitive to gerontological issues, and by clinicians of similar ages when possible. The following is a list of resources that may be helpful for you in treating older adults.